Assalamu alaikum. Welcome everyone on board. Uh, we we started this way of just revising or just planning the concerns with reference to specific patient groups having specific needs or concerns in which you have to anticipate accordingly and prepare yourself for the possible challenges. So in our last discussion, we did pregnant patient, pediatric patient, elderly patient, anemic and bleeding patient, some patient with respiratory problem, smoker, alcoholic, and some addiction. Today we will just start a patient who has risk for embolism. Okay, so as you know that embolism is when something, either it is fat, it is air, it is amniotic fluid, or it is thrombus is migrated from one place to the other place through the bloodstream and blocking the pulmonary artery, leading to no blood going towards the lung, so the cardiac output will be stopped. So basically, embolism is presented in variety of pictures, but usually thromboembolism or air embolism will be relatively more acute if it occurs in a significant quantity or amount, whatever you use the word. And fat embolism and amniotic fluid embolism has more of a subacute picture, or you can say like it's an sort of, there are, because there are theories about it, that it is more of an immunological picture. Okay, so this is some background of embolism. So it will be either fat or air or thrombus of or amniotic fluid. Okay, so one will be relatively more acute than other. So now one by one we will say that at fat embolism. So which patient will be at risk? Like usually any fracture, long bone fracture, and patient with undergoing this what is it's a liposuction, okay, in which also they are migrating. But it can occur in obese patient in some many other ways. Okay, so like as I told you that it's an immunological picture. Okay, sometimes. So what will you be anticipating? So in that case, for example, if you request, like you are requested to anesthetize a patient for any fracture, please make sure, because it's a miscalculation that people ask for investigations. Remember one thing: no orthopedic fracture is elective. You have to do it, and there are like guidelines about because some of the fractures of the lower limb, like femur fracture, hip fracture, they are at significant risk of embolism, both thromboembolism as well as fat embolism. So if you delay for some investigation which will not change the management, you should not do it. So there is a proper guideline about it, so you don't need to wait for lengthy investigations and a lot of things. Okay, so you should be clearly anticipating that if you delay, there will be more morbidity, more chances of morbidity and mortality, rather than if you do at the same time with risk stratification, avoiding the things which can. So um, one of them is that if any fracture, if possible, they can have some art like temporary fixation or temporary stretch, or you will see that a number of fracture they are putting a traction. So actually this reduces somehow pain, as well as because the fracture will be temporarily immobilized, so the chances of will be slightly reduced. So that patient, when you are transferring from the bed, from the trolley to the OR table, please be careful, because there are case reports that that patient, when you are moving, that patient is immobile for some time, and now you move the patient, and there may be embolism, fat embolism at that time. Okay, so you have to anticipate and you have to mentally prepare for it. Of course, the management will be the same: airway, breathing, circulation, and according to ACLS protocol, and whatever is happening, you have to uh, do accordingly. But this will be that you will anticipate that thing. So maybe you can attach, because I'll tell you, majority of time people don't put the monitor while transferring. So I would suggest that it is better, before you start transferring the patient, it is better to attach the monitor. Yes, it will, the your technician will not be too much interested, but it's always safe, at least in this case. At least in this case, that you should attach the monitor, because while you transfer and then you are stabilizing the things, so it is possible that if it occurs, it will not occur in every patient. So if it occurs, then you will be in trouble. Okay. Then to reduce the pain, not only this thing, reduce the pain and stress. Sometimes you can give a little bit of very small dose of ketamine before transferring. Okay, this is one thing. Or you can give any block which will reduce the pain. Okay. So like you can give femoral nerve block or sci-fi block, or like any block according to the fracture which is you are dealing with. So it will not reduce the risk of fat embolism, but at least it will reduce the pain and stress. So this will help you in one way or other. Okay. So similarly, in liposuction, it can also occur. So if any patient at risk, as I mentioned, you will be taking care. Liposuction is also process in which they introduce warm normal saline inside the fat space, and then they break the fat and then they suck it out. So there may be chances of catabolism. Obese, I'm not sure about it, how it happens, but I read somewhere that it can. So it's a controversial thing. Don't mention in fat embolism, but you can just keep if they are asking more and more. So then you can tell. Okay. So then air embolism. Okay. So air embolism you will be expecting in any surgery above the level of heart, in a reverse Trendelenburg position especially. Okay. So because like it occurs in neurosurgery, it occurs in posterior fossa surgery, it occurs in even carotid artery surgery, and even it can occur theoretically, it can occur in even thyroid surgery. Any surgery which is occurring above the level of heart, in a reverse Trendelenburg position, air can suck in and it can cause. So what you will be anticipating, it is better, if possible, you can have T, transesophageal echo. If possible, you can have transthoracic echo. If possible, you can have esophageal Doppler. You can have this one uh, CVP with the dedicated flush with a big syringe. In case it occurs, you can immediately aspirate the air. So these will be the anticipations if you are suspecting air embolism. Rest of the things are the same. Of course, when they are opening the dura, so you can be careful. You can ask the surgeon to flood the area. Okay, they they also use bone wax, so to prevent as well as manage also. Okay, so if it occurs, you will straighten the bed, and then you will move the head side down, and you will try to aspirate. So rest of the things will be uh, symptomatic. Okay, you will be trying to aspirate the air. You will be detecting with loss of end-tidal CO2 and increase in end-tidal nitrogen. Okay, so then you will be managing accordingly. Rest of the things will be the same. ACLS protocol, fluid management, inotropes, vasopressors according to the requirement. So it will be ACLS protocol alongside these things. And the third thing is for example, amniotic fluid embolism. Actually, you cannot do anything. Unfortunately, there is no prevention for it. Maybe if like if you are suspecting, like for example, if this uh, from premature rupture of membrane, or this another terminology I forgot, in which placenta is displaced from its position. What is called in Vanilla Rajun? I forgot its name. Abruption.
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 Okay. Abruption placenta. Okay, so in abruption there will be more chances of amniotic fluid embolism. it can occur even before delivery. It can occur. So even it's in the differential diagnosis of a maternal collapse in labor room. Okay. Of course, there will be differential diagnosis among cardiac causes, respiratory causes, neurological causes. If the patient has epidural, so there will be differential diagnosis, but it will be high suspicion if it occurs. Okay. So again, it does not have a specific uh, treatment, it symptomatic treatment. But they can ask you how to diagnose uh, which patient will be at risk, or I think multipara, or I'm not can recall 100% what are the things. There will be some obstetric reason in which there will be more chances. Some of them I have told you. The management will be the same. Now comes the thromboembolism. Okay. So actually, for thromboembolism, there are a lot of scoring systems, and just a second. Was in this discussion, my aim is to let you know that how will you anticipate, and what will you be doing. So any patient who is at risk of thromboembolism, first of all, you need to filter out any patient with atrial fibrillation, any patient with the you can say stasis, okay? Any patient with POP is there, any patient with the uh, just a second, please. Need to change the connection. Okay. So you will be identifying the patient at risk. So and then uh, you will start thromboprophylaxis. So thromboprophylaxis is a multi-dimensional thing. We only concentrate on the medication. Medications comes at the last, but there are so many things which you can anticipate if you have a patient at risk, like obesity is one of the factor. Any cardiac disease is a risk factor. Any patient with the thrombocytosis is a risk factor. And any patient with the like this one polycythemia vera is a risk factor. Dehydration is a risk factor. Like there are so many risk factors for it. So identifying the patient at risk of embolism is one step. Okay. Then, as I mentioned, that you will try to have minimum invasive surgery. You will try to avoid dehydration. You will try to use of regional anesthesia because it reduce the stress response. So there will be chances, it will reduce the chances of this one. Uh, I think we will find, I think this is treatment. So, so how the thrombus is formed. I just wanted to show you the risk factors. I think it's not written here. I will show you. If you forgot to open it. Mm, Reducing the maybe here. These are nice guidelines. You will find a lot of data here. You just have to, like you see, cancer patients, critically ill patient, okay, renal impairment, any patient with, as I mentioned, cardiac or pulmonary disease. These will be all patients who are uh, at risk of pulmonary embolism. So as I mentioned, you see pregnant patient we discussed yesterday that they are at risk of embolism. And whenever there is risk of embolism, you have to look into consideration the bleeding risk because uh, you have to outweigh risk versus benefit. Because whenever you are using medications, uh, it can increase the bleeding tendency. Okay, so especially like this the medical management like anticoagulants like heparin or Cloxane or warfarin or things like that. So that will increase the risk of bleeding. So in cases in which the risk of bleeding is also there and risk of embolism is also there, so you have to outweigh risk versus benefit. If there is less risk of bleeding, maybe you can continue management till the end. Otherwise, you might need to do the bridging. Okay, so you will do the bridging. It is also true for antiplatelets. So you will, like a number of cases, you continue dual antiplatelet therapy, and then maybe you can 4 days before you stop clopidogrel and you start heparin, and you continue it up to 4 hours before surgery and you stop it, or you start clexane and you stop it. If you are giving therapeutic doses, you stop it 24 hours before surgery, and you are using prophylactic dose, you stop it 12 hours before surgery. And similarly, there is for different all other newer this novel anticoagulants and antiplatelets, you should be knowing the duration of action for those medications that in which the therapeutic will be then way of thrombophylaxis, as I mentioned, that there will be some patient you need to have like minimum invasive surgery, regional anesthesia, okay, early ambulation, use of ERAS protocol, use of opioid free anesthesia. All these things will reduce the hospital stay, and it will lead to lesser reducing the chances of thromboembolism. Like there is a fracture, you try to fix the fracture at the earliest possible time. You, if you are using regional anesthesia, try to have motor sparing blocks. Like for example, in knee arthroplasty, it is better not to give epidurals. If it is better not to give femoral nerve block, it is better not to give popliteal block. You try to have joint infiltration, joint intra-articular local anesthetic with adductor canal block. Adductor canal block is only sensory nerve involved. It blocks only saphenous nerve and nerve to vastus medialis. So actually, it will prevent the motor block. So it will be a better choice. So there are so many things. You see now. I will just have a look. Elastic stocking is one of them. There is a compression system. Okay, intraoperatively, if any patient with risk of embolism, actually there is like a system in which the legs are constantly pressed, like you can say like a massage. Okay, so they are constantly uh, pressing the legs, calf. It is pressing, so it is helping in reducing this TED antithrombotic, this elastic stocking. So they are telling some details in which you are not using it. But just a second. Mm, because this is nice guideline specific. You can have a look if you want to have some detail about these individual regimes and concerns. You can have a look here. I was looking at something else. See, too much details. Just a second. One more thing is that whenever you are using anticoagulant or antiplatelets, the use of regional anesthesia will also be managed accordingly. You have to stop the medications according to the situation. So uh, actually, there was a thing. This is also too much details. This is quite big source, but I compile it whenever I put it here so that you can find uh, risk stratification. You see, this is risk factors, previous DVT or VT, okay, thrombophilia, malignancy, post-operative setting, trauma, indwelling central catheter, immobility, chronic medical conditions, admission to ICU, neurological diseases with extremity paresis, increasing age, obesity, steroids, okay, at hormone replacement therapy, androgen depriving therapy, varicose veins, up to 6 weeks postnatal, first degree relative with history of VT, extended travel. You see, even extended travel. This is also a risk. So, in these patient, you will be uh, taking care of it. Okay. Okay. If, for example, intraoperatively, if this occurs, so it will be with hemodynamic collapse and hypoxia, like there will be hypoxia, loss of end-tidal CO2, and hypotension. Okay. So if you have a patient at risk and it occurs, the first differential diagnosis will be embolism until unless prove otherwise. So what will you be doing? You will be stopping the surgeon, you will be uh, taking care of airway breathing circulation, and the next step will be you will be getting the help of physician or cardiologist for say. Then, of course, at that time you cannot shift the patient. So maybe initially you will try to give heparin in the operation theater to help it out, and then like you will try to finish the surgery or minimize the surgery, and then patient may go to VQ scan, and you will find you might have some finding in ECG, might have some finding in echo, like right heart strain pattern will be there, and in VQ scan you will have perfusion defects. So that will be like a diagnosis. So and then and you see the further management will be according to the situation. Then you will be doing for thrombolysis, and whenever there will be thrombolysis, thrombolytic therapy, there the patient will have at the risk of bleeding, streptokinase of TPA. Okay, and another thing is that if the such patient is coming for any other surgery, emergency surgery or anything, that then this will be helping you out, vena cava filter. Okay, especially if a patient has DVT, you preoperatively in interventional radiology, they put a vena cava filter, which will any patient will who is at risk of embolism. So that all will be according to the uh, guidelines and according to the risk available. Okay. Mm. As I told you, S1, as I was telling you, there was some finding in the ECG. It's S1, Q3, T3. I'm very bad in identifying this. I think in lead three there will be Q waves and T waves, tall T waves in T3. If anyone knows about it, you are welcome to explain the ECG findings in pulmonary embolism. You see, they have written some finding here. A chest radiograph in pulmonary embolism can demonstrate hypovascularity, Westmark sign. I'm really sorry. I'm very weak in it. Diagnostic management of pulmonary embolism and increasing non-invasive modalities like D-dimers, say patients with low or intermediate clinical probability of pulmonary thromboembolism. D-dimers also raised. Mm. You will only move the patient when the patient is stabilized. So our management will be uh, hemodynamic support, airway breathing circulation approach, and these things. And these will be further uh, uh, like diagnosis and further management. Okay. So you see CT angio and VQ scan, as I told you. So echo, you see echo will, as I was telling you, right heart stain pattern will be there. Okay. And pulmonary angiography. If it is subclinical, maybe only have tachycardia, shortness of breath. Okay. And hypoxia. So there will be level of suspicion will be there. If you have a post-operative patient who is at risk of embolism and you are not able to identify any cause of dyspnea, so until unless prove otherwise, you will consider it to have embolism. And embolism cannot don't always be massive. As I told you, there will be minor embolism which can occur, and it will subside without by only by supportive uh, management. Okay. So that's, I think we have discussed enough about. Okay. So now we will discuss few words about Um,